Hello and welcome to a new podcast episode on heart failure realities, the gap between guidelines and practice. I'm Waleed Al-Habeeb, a professor of cardiology and the president of the Saudi Heart Association. And with me today, Professor Gianluigi Savarese, who is a professor of cardiology at Karolinska Institute of Stockholm and the head of heart failure specialist. So welcome.
Thank you very much for inviting.
So this is a very important topic that we're going to talk today about a guideline-directed medical therapy implementation. I know you have been very active and interested in registries and data at Sweden.
Yep.
And would like to know what has the Swedish heart failure data gave us insights about.
Yeah, thanks. That's a great question. So in Sweden, we have quality registries which actually collect a lot of information regarding our patients, including, of course, medications. And this registry has been active for the last 20 years. So there is I would say, long-standing tradition with registry-based research in Sweden. And we have been using very much this quality registry. And of course, whether patients receive or not, guideline-directed medical therapy is, of course, a quality indicator. So that's very well measured. And it's also used for actually assessing the performance of our hospitals in Sweden. So very important information. So our data really allowed over the time to assess trends in implementation of GDMTs. And very recently, we have been checking out how the status is in 2025. And what we have been seeing, at least in Sweden, is that the uptake has been increasing over time, in particular when it comes to RASi and beta blockers. SGLT2 inhibitors uptake is increasing very, very much. So at the moment, more than 80% of patients in Sweden do receive an SGLT2 inhibitors, which is surprising given the fact that it's a quite new drug. And we are talking, of course, about FREF. MRA use is overall more limited, very often, because of fear for worsening renal function and hyperkalemia. So we observe these trends over time in use of GDMT, and together with that, we also investigate barriers to the implementation. And what we understood also from a survey we performed with the Heart Failure Association of the European Society of Cardiology is that many physicians intend patient adherence as a major barrier to the implementation of GDMT. And this was true in our surveying 40% of the cardiologists which participate in this survey of around 400 cardiologists. So what we did in our register was to try to understand more about adherence and persistence to GDMT in patients with FREF. And what we observed is what is a bit expected, that overall adherence in heart failure is higher than adherence in other disease area like hypertension or prevention. Of course, because patients have symptoms, so they try to be compliant actually to reduce the symptom burden and improve quality of life. But still, there was at least 20% of patients in our cohort which were not adherent to quadruple therapy. And what we observed for each GDMT was that whether patients were adherent, actually these associated with very much lower risk of cardiovascular mortality or heart failure hospitalization, which really highlights that we need strategies to tackle patient adherence in patients with heart failure, as we already do in other cardiovascular disease and hypertension.
Very nice. I think so, many of this data is quite universal, very similar to what we have in Saudi Arabia. Now, from your experience, how do you see the significance of registry-based research compared to other types of research?
Yeah. Registry-based research is very important. It also actually leads to better implementation of GDMT. So it allows to monitor GDMT implementation over time, but also patients registered in registries usually do receive better care. We don't know, it might be a bias, residual confounding. Might also be that patients enrolled in research studies actually are more often seen and therefore receive better GDMT implementation. And registries also allow to understand which the barriers to GDMT implementations are, as we saw over the time for some demographics, socioeconomic characteristics, comorbidity burden, And when it comes, for example, to MRA, understanding the link between fear and actual hyperkalemia risk and actually implementation of RASI and MRA. So very important to have registries in our countries.
And that probably takes me to this next question. What signals of undertreatment have you noticed, or what factors contributed to that undertreatment?
So in quality registry, of course, we see some trends which are better as compared to more generalizable real-world cohort of patients, for example, electronic health records, claim data databases, and so on, because they are usually much larger and also more unselected. But what we see in general, for example, I ran a few years ago the evolution of failure study, a huge collection of data from Japan, from Sweden, from United States of America and UK, that implementation was very limited. And was not also only very limited in terms of patients receiving or not the treatment, but also receiving adequate doses of the medications. And there was also limited implementation in terms of speed to achieving GDMT, which was taking very, very long. And this is a big problem because we need to remember that beyond GDMT, we have other medications that we start as second-line treatments, and very often they even require that we have optimized the use of GDMT before. For example, ivabradine in patients receiving optimal maximum tolerated dose of beta blockers or indication for devices, patients should be on GDMT. So it's important to speed up the GDMT implementation process, also to have access to all the other interventions, which are second line, but in any case have been demonstrated to improve mortality and morbidity.
So did these registries give us any insights about the use of these second-line treatments or those special population of patients?
Yeah, definitely yes. They allow us to understand which patients are more likely to get or not to get treatments, which allows to set strategies for implementation. And they allow also another very interesting factor. For example, in the Swedish heart failure registry, we use registry for screening patients for implementation. It's still a research project that I hope we can implement in our clinical practice. But basically, we screen the registry, we identify those patients who do not receive the drug. We have values for eGFR, potassium, so we understand those patients who should receive the treatment. Then we call the patients at home, we ask them to come to our clinics, and we foster implementation. So registries are important for monitoring implementation, actually screening for implementation, understanding the patient categories who are less likely to receive medications, which are then targeted for implementation strategies.
Let me talk about a very important topic, I believe, when we talk about heart failure and many of our patients having comorbidities as well, polypharmacy.
Right.
What's the significance of that in our patient management and adherence and other factors?
Polypharmacy, I think, is a major driver of adherence issues in patients with heart failure. Here we speak about heart failure with reduced ejection fraction. And I don't really think we can speak about polypharmacy in heart failure as we do for other disease areas. Patients with heart failure are by default in polypharmacy. So they should receive quadruple therapy, plus they very often receive a diuretic. So just for heart failure, they will be on polypharmacy, which is 5 or more than 5 medications. So these patients actually receive hyper polypharmacy, something much more. In our study I was mentioning earlier, basically around 20% of patients receive 9 or more than 9 medications. So trying to reduce the pill burden, as we learn from the hypertension field, I think it will be also very important in the heart failure field in order to foster implementation of GDMT. There are data from the guided trial, for example, showing that patients with heart failure on polypharmacy are less likely to receive GDMT for heart failure. So we really need strategies for addressing this point, reducing pill burden. For example, we might consider single pill combinations, we might consider other tools, we might consider also deprescribing of other medications which are not necessary in those heart failure patients at that specific moment, if this leads to a better implementation of GDMT.
Excellent. Are there any other means or measures that can help these patients, like digital solutions or?
Definitely, yes. So I think there is quite good data regarding, for example, mobile apps across the cardiovascular disease spectrum. So why not patients with heart failure should benefit as well of this intervention? This intervention use different strategies, reminders for taking drugs, or gamification approaches. So patients, it's like when we just do our steps because we want to see that on our smartwatch we have done the physical activity that we should do during the day. So it's the same thing. So I think this is really something which might help our patients, also because even older patients have become more familiar to using smartphones and smartwatches.
Now, everyone is using and everyone is talking now about artificial intelligence. Do you see any future in helping our heart failure patients using?
Definitely, yes. First of all, if we use, for example, smartwatches and smartphone, AI can actually provide a lot of data which are important for understanding how patients perform during the day, if they are doing well or not. Some specific devices are even able to detect congestion in our patients. But I think also a role might be played to remind the patients to take medications and also the benefits related to taking medications. So like for increasing awareness and empower the patient to be more actively part of their care.
Any strategies for the healthcare professionals to improve on their communication and education with patients, especially regarding polypharmacy and multiple comorbidities?
Yeah, definitely, yes. I think we should really much discuss more with our patients regarding adherence. We should assess adherence because many physicians actually do not check for adherence. And together with the Heart Failure Association of the ESC, we will have in the next weeks online actually a position statement where we also provide a clear guidance on how to measure adherence in our patients. That should be done all the times. And also important that physicians should also check the medication list of their patients and try to understand what they are taking and what they are taking, because this discussion with the patient actually leads, I think, to better understanding also from the patient side about the importance of taking the medications. And it's also important using checklists. I think that's not bad. Checklist integrating in the electronic health record. So whether a patient is not receiving a guideline-directed medical treatment, actually a alert will pop up and remind the physicians to prescribe. And finally, in Sweden, we have an alliance with our nurses for care of our patients. And nurses spend much more time than us talking with the patients, explaining important factors also related to adherence, while we might not have time as physicians during our outpatient clinic visit.
It's a worldwide issue. Everyone always complains about the time, the limited time, the constrained time. So that these solutions, any other solutions or gaps that can be filled in the heart failure patient journey that we can help in?
There are several strategies that we might use for improving GDMT uptake in daily clinical practice, and there are different targets. So if we target physicians, it's, as we said, it might be very important to highlight the different contribution also primary care might have in the journey of the optimization of therapies, having better and clearer referral pathways between primary and secondary and tertiary care when it comes to optimization of treatment and up-titration of medication. Also, better implementation of nurse-led clinics and better empowerment of pharmacists as well, I think is definitely key. When it comes to targeting actually the healthcare system, better structure of follow-up of patients definitely helps. Whether patients more often meets a physician or a nurse on an healthcare provider, it's more likely that treatment will be screened whether they have been initiated or not, and there would be an opportunity for optimizing a treatment. So the importance of the multidisciplinary team, I think here is really clear. Then I think we, of course, need to target the patient, and we target the patient trying to improve adherence. and strategy as the one we mentioned, the mobile apps, single pill combinations, better communication with the patient, empowering the patients, educating the patients about the benefits of a GDMT actually I think plays a key role.
Very nice. Thank you very much. That was very insightful about the importance of GDMT implementation, the insights from the Swedish heart failure data and registry, and strategies to overcome the barriers in implementation. Thank you, Professor Savarese, and wish you a good day.
Thank you so much.